Okay, my today's talk is managing cytokine production in COVID-19. We are all accepting the fact that COVID-19 has uh, stuck us very hard in last 1.5 years. Started in China back in 2019 December, and then it arrived in India March 2020. And since then, we have been fighting against it. Uh, so my today's talk will be on COVID-19 phases, and then we will go on to how it develops the cytokine storm. What are the guidelines to treat the COVID-19, which has been given by Infectious Disease Society of America? And then we will talk about the evidence of the JAK inhibitors in COVID-19 as it has been approved by FDA, US FDA, in terms of baricitinib. And now we are coming up with the tofacitinib, the repurposing of the drug for COVID-19. Let's start with the 40 years with the coronaviruses. It was found between 1960 to 1970. And then there was the first international symposium in Wurzburg in 1980. And over a period of time, it started hitting the human being back in between 2000 to 2002, 2002 to 2005 in terms of SARS, and then between 2012 to 2015 in terms of MERS, and then in later part of 2019 we were hit with the SARS-CoV-2. What are the COVID-19 phases? COVID-19 phases are usually we have been describing in three phases, and more than 80% of the people are developing only flu-like symptoms, but 15% also develop the shortness of breath, which is called as pulmonary phase, and out of those 15% people, 5% develop the ARDS and cardiac failure, and it's painful to say that more than 50% of those succumb due to ARDS and cardiac failure. So, how an immunity be reinforced and hyperinflammatory damages can be avoided? So we have to understand the immunopathology of the COVID-19. The first phase, the virus entry, and that's when the person in first week the person usually develops the routine flu-like symptoms, and that's when the innate immune response come into picture with first cytokine wave, and that is the time we would like to treat the patient so that he does not develop the deficient state. But somehow, because of if I'm talking about the Indian population mentality, they would not talk about this illness. They would run away, and that's when they develop the immune deficient state, and that is when the cytokine storm come into picture, which is a lethal second wave. Uh, so basically, COVID-19 induces both impairment and hyperactivation of the immune system. Early viral clearance is by IFN type 1, which is a key to prevent further viral replication, T cell exhaustion, and the cytokine storm. Uh, During the first phase itself, with the timely administration of the treatment will reduce the viral load and avoid the hyperinflammation. So this is the kinetic and intensity of the antiviral response. In mild to moderate disease, the viral load which is when the viral load starts rising, but the type 1 IFN response is such high that the inflammatory cytokines will not take much of the person's it will not come into picture in such an extent. But if the treatment will not be started in the early phase itself, then the viral load will increase, and then the inflammatory cytokine will come into picture, and that is when the cytokine storm will start. So it is a very complex immunopathology of COVID-19, but I would like to simplify it. In patients with severe COVID-19, the lymphopenia and drastically low CD4 plus T cell and CD8 T cells, B cells and NK cells, as well as the reduced monocytes, eosinophil and basophils will be seen. Additionally, NKG2A on cytotoxic lymphocytes, including NK cells and CD8 plus T cells, are upregulated in patients with COVID-19. Patients with severe COVID-19 will exhibit the elevated serum levels of pro-inflammatory cytokines such as IL-6 and IL-1B, as well as IL-2, 8, 17, GCSF, GM-CSF, IP-10, MCP-1, MIP-1 alpha, which is also known as CCL3, and TNF alpha, and tissue necrosis factor as well, and which all together will be considered as cytokine storm. The hyperinflammatory response that will rapidly progress, and it will definitely increase the risk of death. Intervention is aimed at modulating the inflammatory immune response by reducing the toxic cytokine levels, which will improve the outcome in the treatment of COVID-19 pneumonitis. The approach is well established since the publication of recovery that lead to the usage of dexamethasone in admitted patients. So this is the infectious disease Association of America guideline in 2021, where they have clearly stated that with mild to moderate disease, we do not need corticosteroids or any of the monoclonal antibodies. With hospitalization, with the no need of oxygen supplementation, there is a minimum evidence where you will be succeeded with the corticosteroids. But yes, they have recommended, they have suggested the use of glucocorticoids, where you see the oxygenation is going down, going below 94% on room air, and person needs a mechanical, either need the mechanical ventilation or the high flow oxygenation. But in any case, the tocilizumab is not clearly evident to be used. Even in recent times, the Roche, the only pharmaceutical company which has been manufacturing tocilizumab, they have also said that it has not met the endpoint in terms of survival. Yes, the remdesivir can be used when the patient is hospitalized and patient is in septic shock as well as on ECMO. There is some amount of evidence in patients with the non-critical disease with SpO2 less than 90%, 94% in room air. Recent advances, what we have been following is baricitinib as well as the remdesivir. Baricitinib is a small molecule JAK-STAT pathway inhibitor. They have said that it can be used in non-critical disease where the oxygenation is less than 94% on the room air, but there is no sufficient data on for the patients who need mechanical ventilation or in septic shock and on ECMO. So currently, I would like to talk about tofacitinib, which is another small molecule which has been came into picture back in 2012 for the treatment of rheumatoid arthritis, and it came in India back in 2014. It is a selective JAK inhibitor for JAK1 and JAK3, and it has some amount of effect on JAK2 as well. And it also blocks the signaling from IL-2 as well as IL-4 and IL-6 and IL-11 as well as interferons. So what is the repurposing of tofacitinib? There are 4 Janus kinase JAK receptors present on the surface of immune cell. It will rephosphorylate and then activate the signal transducers and activators of the transcription, which is states, which in turn modulate the expression or gene expression responsible for the production of cytokines such as IL-1, 4, 6, 7, IL-9, 10, 11, 15, 21, 22 as well. Tofacitinib is a JAK-STAT inhibitor, potent immunomodulator approved for the second-line therapy of several autoimmune diseases. By blocking this pathway, and serum levels of these cytokines are significantly reduced as well. But it is important to note that JAK-STAT inhibitor do not have any effect on IL-1, 17, 18, TGF-beta as well as tissue necrosis factor. So basic, if we talk about the inflammatory pneumonitis, which is caused by COVID-19, more than 50 cytokines are involved. More than 50 cytokines are involved, and in that case, tocilizumab, which is only an IL-6 inhibitor, as well as anakinra, which is only an IL-1 inhibitor. Compared to that, tofacitinib is more reasonable to use as it has broad spectrum at the cytokine production inhibition. There was a study done in Mayo Clinic with 326 patients were taken with the COVID-19 diagnosis. Out of those, 269 developed the COVID pneumonitis. There were 51%, approximately 51% of the patients treated with the tofacitinib, out of which 16 expired. 58 were only treated with tofacitinib, and out of those, only 5 expired. 4 were treated with tofacitinib and tocilizumab. As in August 2020, it was told by FDA tofacitinib and tocilizumab both can be used, and out of those, only 1 patient expired. In those out of 138 patients, 67 patients were only with the dexamethasone, and out of which 8 expired, and 9 were treated with dexamethasone as well as the tocilizumab, which is IL-6 inhibitor, where only 2 were expired. Compared to that, 48% were treated with only dexamethasone. They were included in the group where they were only to be treated with dexamethasone. 30 were expired, and 129 dexamethasone only 29 were expired, and 2 were treated with dexamethasone as well as tocilizumab. Okay. Let's talk about the tofacitinib alone or with dexamethasone or dexa alone. That is what I have shown in the pictorial manner. Total of 44 patients were expired, and 14 people were in the tofacitinib, while 30 people were in dexamethasone group were expired. The proportion of the death amongst the tofacitinib and dexamethasone group were respectively 10.14% and 22.19%. It represents that 70% reduction in the in odds of dying among the tofacitinib group compared to dexamethasone group. You can see the survival benefit. Survival rate is more than 1%, increment in 1% with the tofacitinib group compared to dexamethasone group. Comparing small molecule tofacitinib as with dexamethasone in head-to-head manner, then the hypoglycemia is the common problem with the dexamethasone group, which probably require insulin coverage while on treatment, where the tofacitinib does offer the added advantage of metabolic neutrality. Lack of hypoglycemia and inducing the catabolic state are significant benefit in an obese, critically ill and population. There was a research article where the JAK inhibitor and type 1 interferon ability to produce favorable clinical outcome. It was presented by Walls et al., where the Janus kinase inhibitors, JAK inhibitors, and type 1 interferons have emerged as the potential antiviral candidate for COVID-19 patients due to their proven efficacy against the disease with excessive cytokine release, and their direct antiviral ability against the viruses, include the COVID-19. Of 733 such studies, they have included 4 randomized and 11 non-randomized trials, and 5 of the studies were unpublished. They have concluded that the people with the Janus kinase inhibitors significantly reduced the odds of mortality. There was a significant reduction in the morbidity as well as the ICU admission, and there was an increased number of hospital discharge over a period of time. compared to standard treatment group, which is with the dexamethasone, remdesivir, or other drug. There are few ongoing trials at present. There is a multicentral randomized double-blind trial. Uh, the the phase one trial is over currently, and they have shown the promising result with the tofacitinib. And there is another trial, TOFACO 2. They also have finished the phase one trial, and they have shown the significant reduction in the death rate as well as the morbidity. So, tofacitinib in COVID-19, what is the role? It reduces the inflammation as well as the inflammatory pathology by inducing the immunosuppression. It has a broad spectrum anti-inflammatory profile. There are few published evidence which favor the repurposing of the drug. Survival benefit with COVID-19 hospitalized patient has improved. It has a metabolic neutrality as well. Guidelines recommend the JAK inhibitors for COVID-19. I would also like to share my own experience with tofacitinib as well as the newer JAK inhibitors such as baricitinib, where I have treated some of the patients of COVID-19. The numbers are obviously pretty low, as I have treated 10 patients with the COVID-19 with tofacitinib and 15 with baricitinib, and I can say that I have seen the decent number of results. Thank you. I would like to take the questions.
That was